Major Hagen.
Yes, ma'am.
How are you this morning?
I am living the dream. How about yourself?
About the same. Thank you.
Fantastic.
Well, good morning, everyone. Welcome to Grand Rounds. And today is a clear presentation under the focus area of well-being. Our speaker today is Major Jared Hagen. Our program is sponsored and underwritten by an educational grant through OSU Medical Center. Graduate Medical Education, and a disclosure statement has been signed and is on file in the Graduate Medical Education Office. Major Jared Hagen enlisted in the Army in 1997. He joined as an infantryman directly out of high school and completed basic training at Fort Benning, Georgia. He served his entire four-year enlistment at Fort Campbell, Kentucky as a member of the 101st Airborne Air Assault Division. After leaving active duty, Major Hagen joined the Delaware Army National Guard as a medical administration specialist while he attended the University of Delaware. Major Hagen obtained his commission in the United States military through Army ROTC at the University of Delaware. He graduated the University of Delaware summa cum laude in 2005 with a degree in biology and was commissioned as a second lieutenant in the Delaware National Guard as Medical Corps officer. Major Hagen attended medical school at Lake Erie College of Osteopathic Medicine in Bennington, Florida, and graduated in 2010. Upon graduation from medical school, Major Hagen completed his residency in general psychiatry at Walter Reed National Military Medical Center, followed by a fellowship in child and adolescent psychiatry at Walter Reed National Military Medical Center. Major Hagen's assignments include division psychiatrist for 2nd Infantry Division in the Republic of South Korea, medical director for the residential treatment program for substance abuse at Brooke Army Medical Center, task force psychiatrist in Baghdad and Iraq, medical director for the Child and Family Health Service at Brooke Army Medical Center, and chief of inpatient behavioral health at Brooke Army Medical Center, and currently serves as a forensic psychiatry fellow at Walter Reed National Military Medical Center. It's my pleasure to introduce Major Jared Hagen.
Good morning, everyone. Thank you so much for having me here. I'm just going to go ahead and share my screen with everyone. All right, so hopefully it's coming through crystal clear. Thank you very much for that introduction. It's a pleasure to be here and talk with everyone this morning. I understand you guys there in Oklahoma have a lot to be happy about. If you're a football fan, your Oklahoma State football team is 9-1. And I was looking at the weather there, and I think it's currently in the mid to upper 50s. Here it's in the mid 30s in Washington, D.C. And after moving here from Texas there in San Antonio, this is quite the temperature change. So I'm a bit jealous of what you guys have going on there. But this morning, we're going to talk about something very serious, which is physician burnout. Can also look at it or speak to it as provider burnout. And so this is something that's been getting a lot of attention over many years. And as we'll go through this lecture, we'll see how efforts are being made, and you can see some improvement in how hospital systems and programs are addressing this issue, but it's multifaceted, and we'll talk about many different nuances of burnout and how we can continue to improve and get better in addressing it, supporting one another, and decreasing the overall burden that many of us feel on a day-to-day basis. So for those who have gone into medicine, from medical school on, we've been basically taught that there is no room for error, and we're expected to perform to very exacting and often unyielding standards. even, the law and, talking about malpractice suits, et cetera, is beyond the scope of this conversation. But even outside the field of medicine, we are held to very exacting standards. And so when you start compounding things, which is part of what we'll discuss here today, it can become overbearing. And so due to our own training, it can overwhelm us. And then when you add external factors on top of it, it can become unbearable. We're also, because of the exacting nature of what we do in the field of medicine, we don't want to show fault. Fault is seen as vulnerability. Vulnerability is seen as bad or something to be avoided or ashamed of. And so even when we start to recognize within ourselves, we're not well, we're struggling with something, we're overwhelmed, as in the title of this lecture, we're burnt out, we may not even, and often don't, reach out for help. We don't let others know. And we're not talking about your standard run of the mill, like, I've just had a bad day, I'm exhausted, looking forward to the weekend kind of thing. We're talking about something much more notable, more prolonged, more powerful. So with that, we'll go ahead and start moving forward. So for the outline today, this is the general process we're going to go through and talk about these different topics, ultimately getting to the end where we come to some conclusions and talking about what does the research say, what resources are out there for us, what is the guidance in terms of hospital systems and programs to help address this issue and become more supportive and helpful, not just for ourselves, but to each other and as a profession. So here we'll start off with some very humbling numbers and perspectives on things in terms of suicide. And so we can see here from this 2016 report that anesthesiologists by far have the highest rate of suicide among medical professionals. And so here you can, and we'll go through some additional slides here, but find your respective specialty in this area to kind of get a gauge of where your specialty lies in terms of dealing with or experiencing suicide as a profession. Even one of the things that's is a humble reminder to me is, even as a psychiatrist, you see there psychiatry is number 4 on this list. So we are the professional subject matter experts, if you will, and yet this is not alien to us. We know everything, so to speak. Well, let me rephrase, we don't know everything, but we know what we're supposed to do in terms of getting help, and we encourage our patients and others to do so, to help work through things, and yet we don't seem to do these very things ourselves. As the saying goes, physicians are horrible or bad patients. We don't take our own advice. And psychiatry, as you see here, is no different. I'm sorry. So one of the things, just to add here, so in terms of suicide, many of you may be aware that medical professionals, physicians, have a higher rate of suicide than the general population. And so male physicians have rates as high as 40% above or higher than the general population, while female physicians can be up to 130% higher. And so these are staggering numbers when we really step back and think of it. And as I just alluded to a moment ago, a study back in 2013 showed that physicians who committed suicide are less likely than the general population to seek out mental health treatment. And so again, this just goes back to that comment about how we don't take our own advice. We don't do what we know we need to do, which then goes back to the initial slide of the reasons why we may not do that. The exacting standards and the belief that we're supposed to have all the answers. We don't make mistakes. In acknowledging a mistake or acknowledging you're overwhelmed is seen as something to be ashamed of and thus avoided. We don't talk about it. And that's something that is getting worse, or is compounded, if you will, by social culture, which I'll talk about in later slides in terms of avoidance of confrontation or difficult conversations. So here I wanted to just give a little bright light or positive information, if you will, to start. So this is the report back in 2017 showing which fields of medicine are at the highest rate of burnout. ER up at nearly 60% of ER physicians that were surveyed qualify or met criteria for burnout. So this is 2017. Now, if we look at the most recent data here in 2019, we can see some significant improvements where ER was at the top at nearly 60%. Here, urology is at the top at 54%. Now, if we go back, you can see urology, which was 11th on this list, was at 52%. And so here they're at 54%. So not everybody is moving in the right direction, so to speak, but as a whole, you can see that a lot of effort over the last several years has been paid to burnout, and we are moving in the right direction as a profession. But still, when you think about the fact that over half or nearly half of all providers in many, many fields are still burned out, and all the patients that those providers give care to, that's the numbers are still startling and require a great deal of attention. So what is burnout? It's an emotional triad of emotional exhaustion, depersonalization, and feelings of lack of accomplishment. And I wanted to make note of the feeling of lack of accomplishment as opposed to an actual lack of accomplishment. If you're a physician and you've worked your way through undergraduate medical school, currently in residency, or an attending physician, you are very accomplished. Even if you're not a researcher, et cetera, you're still an extremely accomplished individual. And so it's a perception of accomplishment, which again goes back to what we were talking about a few moments ago, is the exacting standards that we place on ourselves. Related to this dynamic is that a lot of physicians either have significant traits or possibly even meet criteria for what's called obsessive-compulsive personality disorder, or OCPD. It's not the same as OCD. It's most of the time when somebody says like, oh, they're so OCD, they're like everything has to be the exact way it's supposed to and line up. And one of the military words we use is dress right dress. So everything has to align. Like that's not OCD, that's OCPD, which is this rigid obsession about rules, structure, what's morally and ethically appropriate, et cetera. And so it can make us inflexible, and we are unable to see shades of gray. And so in our mind, as we talk about burnout, this can also apply to feelings of accomplishment. If I'm not meeting this very exacting standard of success, I am therefore unsuccessful. If I haven't accomplished this step, I'm therefore unaccomplished. And so because we can think in these very right and wrong, black and white dynamics within our own minds, it can emotionally tear us down. Professionally can make us very accomplished. So there's two sides to every coin. This is why many of us can memorize algorithms, and we know when there's, the blood results show this, or the imaging shows this, these are the next steps we are supposed to follow and do this. And so that obsessive nature about routine, right and wrong, structure in many respects can make you a very good, if not great physician, but if not kept in check, can result in overbearing expectations, unrealistic expectations. And so in here, the lack of feeling accomplished and happy with the choices that you've made. Study in Europe back in, I believe it was 2016, showed that in terms of residents, up to 20% or a little over 20% of residents were burned out in their field. And so they're just getting started, and yet they're already burned out. 12% of those individuals, 12% of the overall study group had endorsed at least experiencing suicidal ideations at least once during their residency. And 1% of that 12% endorsed having suicidal thoughts many times. And so individuals who are burnt out are 3 times more likely than those who are not burnt out to struggle with suicidal ideations. And so very, very serious. Another study showed that 20% of medical residents met criteria for depression. So that's quite significant. And of those, 74% of that 20% met criteria for burnout. So the correlation between emotional health and burnout is very strong. There's ongoing research to really show us how strong that correlation is, but we do know there is a strong correlation. Of note, when overwhelmed and struggling professionally, physicians have a greater rate of, in each of these criteria, in each of these areas regarding emotional exhaustion, depersonalization, and lack of accomplishment compared to the general population. So no study I've found really gets into why that is, but I have my suspicions in terms of what I've alluded to regarding just the emotional makeup of a lot of physicians in terms of those exacting standards we place on ourselves in our personal and professional lives. So just getting a little bit more into the definitions of what each of these criterion for burnout are. And as I alluded to earlier, when we talk about burnout, we're not talking about I'm burnt out today. Today was just a rough day. It was a long day. It started early, went late. I had additional cases if I'm a surgeon, or maybe there was walk-ins, et cetera. We're talking about day after day, week after week of this, to whether we don't feel or experience a reprieve from the stress that we're dealing with. And so we start to become exhausted emotionally due to just that accumulation, that unyielding stress that we feel day in and day out. The depersonalization aspect is how that emotional exhaustion then can translate to our patients, to where they're coming to us for help, and our initial thought after we read their chief complaint or whatever is calculating the amount of work or emotional energy we are going to have to put forth to provide care for this patient, and which then in turn translates to or impacts the quality of care we provide to the patient. And then I spoke at length already about that lack of feeling of accomplishment, and thus that reduced satisfaction with our lives and our careers. So when we start talking about what contributes to burnout, one of the biggest factors, and we'll see more of this, is the bureaucracy and the inefficiencies of many systems. The larger a system becomes, the more it tries to focus down on inefficiencies, and the more it tries to focus down on inefficiencies, the more restrictive that system can become to the individual working at the ground level, in this case, seeing patients. And that results in the second point here, in that loss of autonomy. And so a lot of physicians go into medicine to practice medicine within the scope of their practice and the research, but to have a bit of latitude in how they do so, and how they work with patients, and perhaps even as far as like exactly how they document. But again, the more systematic overlays focus on inefficiencies, the bureaucracy, the concern about the medical legal aspects, and thus we have to document a certain way, or to put this phrasing in, it has to be exactly like this, and you have to ask these questions with every patient encounter or every intake. And you might even be saying, like, why does this even matter? I remember one of my recent positions as a child psychiatrist, and I was mandated to ask about dental care. And I'm like, I don't think I'm the right person to ask about dental care, but because of these layers, they're like, well, if you can catch it and then refer them, to, the dental clinic or whatever, it'll catch, this patient population, et cetera, et cetera. And so it's all these layers. This adds on. And so becomes very tedious. And so here you can see with the electronic health records, the EHR, we spend over 50% of our time just entering data. just working in the records and the charts. And most of us, I don't think, had any idea that we were going to spend this much time staring at screens to document the 20% of our time or 27% of our time, which is spent in patient care. So we spend almost double the amount of time documenting what we actually do with patients. So for many, that seems completely reversed. We should be spending well over 50% of our time seeing patients and 20 to 30% maybe documenting, coordinating care, other administrative tasks. And so we seem to have this reversed, and this is a great source of frustration and burnout for many providers. They also feel undervalued and diminished by their administration. One of the things that perhaps many of you have noted and seen articles on and research is this geometric logarithmic increase in medical administration, over the last 20 years. And so what that is, again, leading to kind of goes back up to the first point here, which is the bureaucracy. And so it's like, no matter how much we do, it never seems to be enough, never seems to be appreciated. It's like, well, great, now that you figured this out, let's focus on this and do this and get better here. And it's like, oh my goodness, when can, when is enough enough? As the saying goes. Excuse me. And one of the aspects here that we talk about with regards to the bureaucracy and administration is many of the decisions regarding clinical care are made by those who don't or have never seen patients. And so that can create a great deal of tension when a provider is being asked to do something a certain way, don't do this, or please do that. And it sounds very easy and simple, perhaps to some, but then the provider's like, it's actually not that simple. One of the things that I love personally is carpentry, working with wood. And that's kind of one of the things I do to just decompress and enjoy myself, is disappear into my garage, at least before this last fellowship, and build something out of wood. And my wife occasionally would come up with projects, and she'd be like, oh, honey, can you build this weekend? And I'm like, that sounds simple, but that's actually a multi-weekend project, possibly a month or more, to build that, dresser or desk or this and that and the other. But she didn't, because she's not a carpenter, doesn't work with wood, she doesn't quite understand that. And so I feel like there's a analogy here with administrators who don't see patients asking providers to do things a certain way. It's well intended and they're trying to work with the research, so they come from a good place, but they may not necessarily understand what's going on or how things actually play out in a clinical encounter. And so here we can talk about how more efficient an electronic record is, but now because it's more efficient, we are expected to spend more time, document more. And so anything that's a good thing, if there's too much of it, becomes a bad thing. And so we're seeing a lot of that. And then here towards the bottom, I chuckled to myself where here at 17%, where it said lack of respect from patients. And I remember seeing a t-shirt years ago that said, don't confuse your Google search with my medical degree. And so that's something I know a lot of physicians experience. Is a patient will come in, they're like, well, I found this article here, I was reading on this that says, these symptoms, this is the diagnosis, this is the treatment I want. And then it become this debate between the physician and the patient as to what the symptoms actually mean, what tests need to be done, what treatments are appropriate at this time, due to their 15, 20-minute, search online and reading of a couple of articles. So now kind of moving into a little bit of what constitutes or what can happen within a job system. Excuse me. My computer isn't working properly here. I just got to fix this. Sorry about this. All right. So we've talked a little bit already about overload. We also have conflicting job demands oftentimes where we're expected to be in two places at once. I don't know how your system operates in terms of documenting the hours that you work and how it represents what you do. But in the military, we have this system called Dimmer's Eye, and it really is not effective at showing what we're doing on a day-to-day basis because it's so complicated. And so we have these conflicting, we're trying to be in multiple places, and perhaps administrators are looking at your hours and saying, well, you're only here for this amount, so you have this amount of time. It's like, no, actually, I can't be there and do this because I'm doing this. And it's like, well, it's not shown here, so therefore it didn't happen. We also may not get adequate training or information on how to do the job we're expected to do. Oftentimes we can be victims of our own success because physicians tend to be quite intelligent, resourceful, capable of figuring things out. An assumption can be made that we will or you'll just be able to figure it out. And then without saying anything, because again, that whole, I don't want to speak up, I don't want to acknowledge that I don't have the information or that I may make a mistake, etc. We don't say anything. We just, grit, bare our teeth, perhaps complain to ourselves or friend, family, loved one. But we don't acknowledge that we don't know what we're supposed to be doing or how to do it well. And then we accept all the criticism when it doesn't play out the way we wanted it to or is expected to. Also, one of the things that is very present in today's system is the absence of support from not just supervisors, but from coworkers. One of the consequences of a very litigious society is oftentimes not just the fact of protective medicine, but the fact that I don't want to open myself up to criticism, ridicule, potential legal responsibility if I don't handle something in an appropriate way. And so even within our own community, we're not supportive of each other because we're thinking of ourselves first. I need to make sure I don't lose my job or my reputation, et cetera, doesn't take a hit as a result of this situation because I seem too lenient or I didn't handle it this way and refer you to this, et cetera, et cetera. And so as a provider, how do I feel supported when I know that my supervisors and coworkers are likely at times, if not based on history, expected to support themselves first, and then whatever's left over, so to speak, is the support that I get. So this system, these types of systems can contribute heavily to burnout. Another thing on that we haven't necessarily discussed much about yet is requirements to display or suppress emotion, and this requirement that providing medicine is similar to customer service, and not customer service as some of you may have experienced today, where you go in to talk with someone that works there and you get that response that's kind of like, I didn't come here to work today, please leave me alone. And you're just like, oh, okay. But more in terms of the patient is always right. And so if they're unhappy with something, that means whatever they're unhappy with is a problem that needs to be fixed or resolved. And as a physician, you're like, I'm trying to do the right thing here. They didn't require a medication, or that's not the process that we use, et cetera. So because that autonomy is taken away, the bureaucracy, and so this requirement that the provision of medical care should be of a customer service base. This is not the same, and I want to be clear, as having good bedside manner. Bedside manner is a completely separate aspect of medicine, as opposed to believing that the practice of medicine should be a customer service, oriented profession. And so, again, the requirements to display or suppress emotion, that we're supposed to be even keeled, all the time, regardless of how something goes, even though we're working in very high stress environments and dealing with at times very emotionally, if not physically traumatic patient encounters, et cetera, which I'll talk about here in a moment. And so there's all these factors going on simultaneously, which shows the multifaceted, layered aspect of what drives burnout. And so now we've kind of spoken a lot about what drives and creates burnout. So now we're just kind of shift a little bit into like, okay, what do we start paying attention to so that we can move past it or prevent or minimize burnout or address it when it presents itself. So one of the things that a lot of people do, and I've been guilty of this myself, is we ignore our needs, both for sleep, exercise, perhaps even some like hygiene. We start skimping because our time pressures are so great. And so instead of getting up, maybe you go for a run in the morning to kind of get your day started, get the blood flowing, et cetera, and then, get ready and go to work. Now you're like, I'm just going to get up, get ready and go to work. Or maybe you exercise in the evening. So, well, I'm not going to do that because I really want to just get these reports and, knock them out, et cetera. So the things that we do for self-care, we convince ourselves that we don't need to do, and we start doing less of, under the belief that, well, if I do this, then I'll be able to catch up. And so, which oftentimes doesn't go along with what we actually know from an intellectual standpoint, which is no matter how much work I do, there's always more work. And so in some conversations, we'll make that comment where there's always going to be plenty of work for me to do. Doesn't matter if I'm there till 5 p.m. or 8 p.m. There's plenty going to be there on my desk in the morning when I get back in. And yet we still convince ourselves, well, I'm not going to work out today so I can get this done, or, et cetera, whatever those things are, those hobbies. We don't set limits at work in terms of what we can or cannot do. Perhaps that's due to our own needs for accomplishment, and we want to try to prove something, whether to ourselves or to others. And so we won't set limits. We won't say no when something is requested of us. One of the things that we also may do to try and make ourselves feel better is overspending. And so we'll put ourselves into financial debt to treat ourselves on when we do take vacation. And we won't even get into whether or not you take a computer or work with you when you're supposed to be on vacation, which is a whole another aspect of this. But just to say really quick, if you do, you really might want to look up, if you're not familiar with the criterion for obsessive-compulsive personality disorder, because that's one of the things that a lot of people who struggle with OCPD type symptoms, or perhaps even meet criteria, will do. They'll take their work laptop or whatever with them on vacation, and they're like, well, I'll just get up for a few minutes, and so before we go out on the theme park here at Disney, I'm just going to check emails and this and that and the other, even though I've passed off everything that needs to be done to the person who's covering for me, et cetera, et cetera. And so I'm still not able to leave work and thus fully relax. And so that's both an aspect of not setting limits at work, as well as OCPD. And then maybe I put myself into financial debt to take a trip to Disney with a family that I really don't have money for at the moment, because I need it in order to relax, but yet I'm still not really relaxing. And so you can see the cyclical nature of all of this. And so how we break that is we really need to start setting aside time to take care of ourselves outside of work, setting that limit and saying, okay, when I leave work, like, unless it's an absolute emergency, and we'll talk about how to do that here in a minute, unless it's an absolute emergency, I'm not at work. I'm now at home. I'm with my family, or maybe I'm out with friends, hobby, whatever it is I do in my evenings to relax, de-stress, etc. And so we need to create or find balance in our lives where perhaps there hasn't been prior to, in terms of our physical, mental, and emotional and spiritual health. One of the things that I've noticed in talking with individuals about burnout is when an individual becomes burnt out, it's oftentimes the first time they've really acknowledged they have a limit. So perhaps going through grade school and high school, because they're very intelligent, they really didn't have to push themselves to their limits in order to get good grades and get into college, get into medical school. And then of course, medical school is its own animal, but they still hadn't necessarily reached their limit. And it's not until, they get into the practice of medicine where I have to see patients and then I have to document a certain way. And I have these administrative or supervisory roles and responsibilities. And, oh, I'm also trying to do this research here. And my spouse and I, we just had, a child. And so I want to be home and spending time, with my spouse and family and do this. And, oh, and I want friends to come over for the weekend and we're going to barbecue. And now I have all these things going on, except there's only 24 hours in a day. And no matter how intelligent or driven, energetic we may be, there's only so much that you can cram into that finite space. And so it may be the first time they've realized I have limits, and they don't like that. They've never had to set limits for themselves before. They've always been able to ratchet up to another level, go, yep, I can do that, I can do that. And now they're realizing I can't do that. And they don't want to accept that. And also because it's their first time, they don't know or have a system on how to manage it. They don't know how to necessarily talk to someone or reach out for help or acknowledge to a supervisor, et cetera, that they have overburdened themselves. And so finding that balance, trying to learn what you may not necessarily know, and accepting, I don't know this about myself because I've never been here before. I've never occupied this emotional space. And so here, having open conversations. Now, taking a moment here, open conversations is something that we are seeing less and less of in our society today. More and more conversation is occurring electronically versus face-to-face. There's many problems with that, and not to get too off track, but because this is so central to managing burnout and correcting the trajectory we're on, I do want to take a couple moments here to just talk about the importance of actually having a face-to-face open conversation. So one of the things that we've noted, I believe it was 2014, so this is years ago, and it may have actually gotten worse. There was a study that came out that showed prior to the advent of smartphones and social media, the average adult could recognize roughly 200,000 facial expressions, the subtleties of, when eyes and lips and et cetera move, like if that person is happy, sad, et cetera, et cetera. By 2014, that had dropped from 200,000 to 140,000. So we had lost roughly 1/3 of the skill to recognize facial changes, facial expressions, because we don't look at each other anymore. And we all recognize this, and we may be even guilty of it, that we go out with friends and we're sitting around all on our phones and we're talking to each other about what's on our phone or smart device, as opposed to being physically or emotionally present with one another. And so this makes it harder for individuals to have an open conversation because we don't do it. And so when we hit a point of, say, burnout, or we're approaching burnout, or perhaps starting to feel depressed, which then has a high correlation of burnout, we don't know how to reach out to other people. Research also shows that when we do this, when we start to get that way, instead of talking to somebody, we put it out on social media and technology. We'll text somebody about it or post an update on whatever social media account about it. Except, how can people who are not physically present with me be truly supportive and helpful? Maybe they try to say things like, you've always been tough and resilient. You'll get through this. Just stay the course. And we'll say something that is intended to be sympathetic to the individual's strife, but it actually creates separation because it's not empathic. Empathic, let me rephrase, you don't need to, but it's definitely much more helpful when I'm in person, and instead of saying, trying to find that silver lining, et cetera, which is sympathetic, is just acknowledging what the other person is struggling with. Be a sounding board if necessary to show empathy, not sympathy. Oftentimes we don't understand the difference, and that really plays into how we have a conversation and whether or not that conversation was helpful. And so recognizing these areas that you or others may struggle with is what creates change. Is that awareness that as a supervisor, the way that I mentor hasn't been as helpful as I had hoped or intended to be, because again, if I'm exacting, it may be hard to acknowledge that within myself, that all the effort that I've put forth to be a good supervisor, good peer, mentor, etc., hasn't resulted in the outcomes that I wanted to, and people actually don't feel comfortable coming to me as much as I would like them to. Also because I'm busy, and so I perhaps I don't give them the necessary time that they need to talk about and work through what they're struggling with. Another thing that we don't do that is very helpful is consider the long-term costs of our unhealthy coping. Many of us, as I was talking to before, where we'll stop doing the things that bring us joy, happiness, ease, contentment, peace of mind, etc. We stop doing those thinking there's going to be an end to this process, all the while knowing there's always going to be more work. And so we don't think about it long term. We just think about it day to day, week to week. And it's not until perhaps a conversation such as this one during a grand rounds or with a spouse or friend or loved one that you realize I've been living this very short term unhealthy coping strategy for months, if not years, under the false belief that it's going to get better. And so we don't consider the long-term costs. And so when we start thinking about what are those long-term costs of the choices I'm making now, it can perhaps give us incentive and the perspective we need to make the changes that we've talked about making, but haven't actually moved upon. And then really assessing how successful those current strategies, are in dealing with the burnout that you're feeling, the changes that you're trying to make, et cetera, et cetera. And so being honest with ourselves as opposed to speaking in terms of our ideals. And so when we talk about ideals, what I'm getting at here is we often tend to see ourselves in our ideal sense. I know what I was trying to communicate. I know what I was trying to do. And so the way that I approached it, the words that I used, the system that I implemented were all under this guise of this idealized intent or desire. And it's a struggle for us to really realize how we actually are, how we come across to others. And so that really gets in the way of us acknowledging the mistakes that we make and thus being able to cope with them. So instead of becoming defensive or angry and agitated, which doesn't allow us to acknowledge our mistake, it often projects those mistakes onto others, that if, they were listening or they asked questions, something that someone else did as opposed to us, then this problem wouldn't exist. Well, if I'm always looking to others as the solution for how I feel, I'm not going to acknowledge my mistake. Thus, I'm not going to be able to work through and cope with that error. And so perceived and or real errors can be emotionally devastating, especially for those of us with very exacting standards, that perfectionism, as we talked about here, not necessarily wisdom. Often we seek perfectionism. And so the culture of medicine has historically been about being perfect. We don't make mistakes. We always make the right diagnosis. We prescribe the right medication at the right dose for the right amount of time, et cetera, et cetera. And thus, with those expectations, we can't show weakness. And we often internally will assign blame when things don't work out. One of the things that can be helpful here in identifying how or why we seek perfection within ourselves is looking for figuring out our own biases. And so an easy test here, an example to show like what kind of bias I'm talking about in terms of implicit biases. If I say peanut butter, some of you may say, oh, crackers, that you like peanut butter and crackers. Others might think celery, they put peanut butter on celery. The vast majority of individuals will say jelly. Like, so the moment you say peanut butter and bam, jelly pops into your mind, that's an implicit bias. There's this emotional connection between these two entities. You didn't have to think about it. It just happened. Well, we do the same thing with ourselves, with our patients, with our friends and family. These implicit biases that we don't realize are present, we will often deny, again, because we can't make mistakes. We don't make errors. Everything I do is very thoughtful and intentional, which leads to, again, going back to that, our emotional understanding versus our intellectual understanding. Physicians, in my experience, tend to be very intellectual in terms of how they understand and work through things. And what that really does is it denies the other side of the coin, which is the emotional impact, which again is at the core of burnout, is our emotional feelings. And so if I'm always focused on the intellectual, the nuts and bolts of something, in this amorphous, ambiguous, emotional state, I don't want to deal with that. I'm just going to look at, okay, well, if this happened and this happened, then I'm going to do this, which is going to result in this, and I'm going to ignore those messy emotions. Perfectionism. I don't want to acknowledge that my emotions are imperfect, and I may have these biases that don't align with who I want to be, and how I want to practice medicine, how I want to treat myself, how I want to treat others. An interesting fact is, even when we believe we're being completely intellectual, our intellectual decisions are rooted in our emotional belief systems. It's all filtered through. When you read an article, you filter the facts of that article through your emotional lens to determine what's most relevant and what's most important, which is why, whether you're talking about religious texts or research articles, you can give a group of individuals those same things, they read it, and you'll get different responses in terms of what was the most significant aspect of that study and this research and what needs to be applied, and you'll get different answers. Well, how can that be? It's the same information. Well, it's because you grab what's emotionally relevant to you, and despite your reliance on the facts as you see it, those facts are filtered through your emotions. And so if, again, you believe you have to be perfect, that's what you're going to gravitate to. That's what your implicit biases are going to gravitate to. So when it comes to coping, with error, we need to talk about the event. We need to acknowledge our own imperfection. We need to forgive ourselves, which for many of us is very difficult, and then teach about it. One of the things here that is difficult is talking about the event. Oftentimes within hospital systems, our supervisor may be part of an RCA, an investigation analysis that's supposed to be for learning purposes to improve, but is handled very much like an interrogation. And so the individual who's made the mistake doesn't feel like we're just trying to learn and get better. They feel like they're being punished and that they failed, and their supervisors don't want to talk about the details because they may be asked to provide a report or something. So, well, so who do I go to? Who can I talk to about this that has more experience than me, that's in a supervisory role that I feel comfortable talking to? And so that can be a challenge in a lot of systems, but it's absolutely important to figure out and identify those individuals when an error or mistake has occurred, so that the individual can work through those challenges. So one of the things that that the research encourages is that at the end of every day, you need to take at least, at a minimum, 5 minutes to unwind, reflect on the day, do something that's relaxing, etc. Now, I want to be very clear about here. So here it says, the research says watching television and listening to music and things of that sort. Personally, I don't generally advise or recommend those. This is what the research says. The reason being is I can use those as a distraction. I can listen to music that distracts me from work or what I'm struggling with, or watch a TV program that distracts me from my own emotions. Sure, it allows me to calm down in the moment, and they can be very helpful for those purposes. But it's taking time to sit with ourselves and just reflect on the day. So if you are going to listen to music, it's something I would encourage that it's relaxing, it's in the background. You're just kind of creating the mood or the atmosphere. So maybe classical or something without words. If you know you're the type of person that once you start hearing words and you know the song, you're going to start singing it. But giving yourself just 5 minutes, not a long time, but just 5 minutes to spend in this time. The reason for 5 minutes is that research has shown we need to be bored for 3 to 5 minutes for our brain to shift into our best critical thinking and problem solving mode. But oftentimes we don't allow ourselves to become sufficiently bored for this to occur. We immediately pull out a device, as it says here, watch TV, listen to music, something to distract ourselves. So we don't actually become bored, and thus we don't work through what we're struggling with. And so those emotions just build up, build up, build up. Another thing we don't do very well is prioritize the things that need to get done. We just lump it all together. It's probably all on the same list. This is what I have to get done today. But there is no additional categorization of what has to be done versus what I would like to get done. But if it doesn't get done, so be it. The reason this is important to do that is it helps us not to feel like we failed. If the perception that we have for ourselves is that all these things that listed have to get done, and then I don't get all of them done, it's easy for me to feel that I was inefficient, that I failed, I made mistakes, et cetera, versus if I recognize I just didn't have time, I prioritized, et cetera, I can forgive myself and to say, well, I didn't have time to get to that today. And so for self-forgiveness, et cetera, is very good in this process. So we talk about, goals for managing stress and managing burnout. So here on the right is just a long list of things that are very helpful in asking yourself as you go through this list, how many of these things do I actively do? One of the things that, I wonder, just want to draw your attention to is the active optimism. How many of us or how many of you actively seek out an optimistic way of looking at something, not to avoid the reality of it, but to find something positive, a way to go like, okay, I made this mistake. How can I learn from this to be better next time? We don't seek that optimistic viewpoint. We focus on the negative. Well, as a result of this mistake, this is going to happen. It's going to go on my record. I'm going to have to report it to the board, this and that and the other. And we just, catastrophize and go all the way down this negative scale. We're not seeking any optimistic aspect of this experience. So very important to really be honest with yourself about what you do here versus what you believe or perhaps don't do. So one of the things that has come out and has been out for a few years now and has great data to support is this Harvard protocol, which is basically this self-assessment that really, when we're honest with ourselves, gets at how happy or unhappy we are and what stressors or traumatic stressors that we have. Now, secondary traumatic stress is when you're seeing a patient, let's just say, and maybe we'll say ER doc, the patient comes in from a motor vehicle accident and you stabilize them and they go off to surgery, excuse me, but then you're talking with the spouse, the loved one, and you're dealing with a person who is fearful, terrified perhaps of losing their spouse or their loved one or their child, et cetera. And so that is secondary traumatic stress for you to process and work through. And if you work at a level 1 trauma center and you see this regularly, or just maybe just by the nature of where your hospital is, you see these kinds of things regularly. If I don't acknowledge those secondary stressors, those secondary traumas, it makes it very difficult to process them and work through. And that's what this scale really helps tease out, is these 3 domains and where do they rank in your life. And so getting a sense of that, and there's slides I have supplemental that you can review that actually has information to really get a sense of how well you're doing with these or how poorly you're doing with these. And depending on how poorly you're doing in these areas, that can then hopefully motivate you to take some additional steps to address the areas that you're struggling in and not doing as well as perhaps you thought or would like to be doing. Other things that you can use to help, not just with the system that you're working in and make changes in that system, but within yourself, is these implicit association tests. So on this link, and I have a supplemental slide that shows there's literally a dozen or more tests that you can take that help you see what implicit biases you may possess. And you can do it, I'm pretty sure you can do it anonymously, or perhaps as a resource tool. You can make it part of a didactic that's done autonomously, and then working individuals can take from that what they will and move forward on how to make themselves a better provider, more emotionally healthy within themselves, etc. There's also a video series. Peanut butter jelly is also related to implicit biases that can be very, very helpful in addressing some of the racial and systemic aspects of medicine that we may not be aware of. And then there's some other articles here you can read. And so in conclusion, when it comes to what you can do or we can do to stem the tide of burnout, is we have to make it personal. And because we struggle with that, it makes it difficult for the field of medicine and many hospital systems to do what's necessary in terms of stemming the tide of burnout. We have to get personal. We have to be willing to acknowledge where we're at, what we're struggling with, what we're seeing within our clinics and within our specialty, within our hospital system. I know a lot of systems are working to identify role models and improving the communication between junior providers and more experienced senior providers. One of the things that I encourage folks to do, if they enjoy reading, if you haven't read the book Tribe by Sebastian Junger, it is a phenomenal book, and it really talks about how relying and opening up to each other and having that emotional connection is tremendously powerful and helpful for us. And I think it has a lot of bearing here on burnout in terms of the resources that we can use to help each other. And so with that, I will stop. I believe I'm almost at time for any questions. I hope that means I answered everybody's questions in my 55-minute rambling. And
Well, Major Hagen, that was an outstanding presentation on burnout, and certainly has given us a lot to reflect on in our own personal journeys, professionally and personally. So thank you so much for being able to join us this morning. And we sure would look forward to having you back sometime in the future.
fantastic. Thank you again. Thank you for the opportunity. I wish everybody a glorious Tuesday, and enjoy your warm weather down there.
Thanks so much. Bye for now.
Bye-bye.